Next paper is from Germany. The topic is the role of somatostatin analog as a combination with lutetium, octreotide, and maintenance therapy in metastatic neuroendocrine tumors.
Thank you for the introduction. My topic today is the role of somatostatin analogs as a combination therapy with PRRT and maintenance therapy in metastatic neuroendocrine tumors. As you know from a recent NETO-1 study, PRRT plus octreotide resulted in superior progression-free survival and overall survival when compared to octreotide alone. Here are shown also prospective studies from octreotide and lanreotide compared to placebo. It is unclear whether there is advantage of the combined therapy PRRT plus octreotide compared to PRRT. Therefore, we aim to investigate whether there is a survival benefit to adding somatostatin receptors analogs to PRRT as a combination therapy and to maintenance therapy. In Bonn, we treated more than 400 patients from 2004, and we assessed 421 patients for eligibility. More than half of the patients were excluded because they did not meet the inclusion criteria, because they had short overall survival, or there were no clear group separation possible. We included 168 patients in the study and divided the patients in two groups. Group 1 were patients treated with PRRT monotherapy and no maintenance therapy, 81 patients. And Group 2 were patients who had somatostatin analogs as a maintenance therapy, some of the patients had also combined therapy PRRT plus somatostatin analogs, Group 2. The number of patients in both groups was similar: 81 patients in Group 1, monotherapy, and 87 patients in Group 2, maintenance therapy plus minus combined therapy. Inclusion criteria in the study, in this retrospective study, were G1 to 2 neuroendocrine tumors, GEP-NETs, and multiple unresectable metastases. The patient should have adequate tracer accumulation under imaging, somatostatin receptor imaging, such as gallium, PET-CT, or octreotide, octreotide scintigraphy. The patient should have good ECOG status, 1, 2, or 0, and the patient had to have a long follow-up to see the difference. To exclude bias in this retrospective study, which is really difficult, we had to compare patients' characteristics and tumor characteristics. Here we have the most important characteristics, such as gender, age, ECOG, tumor type, functionality of the tumor, Ki-77, tumor burden, tumor marker, metastasis of the tumor progressed prior to PRRT. All these characteristics were not significant different in both groups. Also, the majority of the previous therapies prior to PRRT and somatostatin analogs as a maintenance therapy were not significant. The only significant difference were somatostatin analogs previous to therapy. As you can see down here, there was a significant difference. We therefore tested if somatostatin analogs prior to PRT had significant factor on the survival, and there was no significant difference. About 50% of patients in group 1 had somatostatin analogs prior to PRT, and about 65% in group 2. Materials and methods. Both groups were treated with a median of 4 cycles PRT, 7.4 GBq in group 1 and 7.1 GBq in group 2. The median administered activity was 30 GBq in group 1 and 32 GBq in group 2. In group 2, patients received somatostatin analogs each 4 weeks. And of course, in the group of the patients who received combined therapy, the somatostatin analogs were discontinued for 4 to 6 weeks before PRT. The reason was to avoid interactions. Here shown the results of the study of the survival, progression-free survival, overall survival, response, and death events. As you can see, the second group had really very similar survival to the NATO-1 study, 48 months. And in group 1, with PRT as monotherapy, the survival was just 27, the progression-free survival was just 27 months. The same with the overall survival, much longer with, in group 2, 91 months, and only 47 months in group 1. The response rate were higher in group 2, 63%, and 40% in group 1. The clinical benefit rate, which means objective response plus stable disease, was about 80% in group 1 and 95% in group 2. The death events rate was higher in group 1, 63%, and 36% in group 2. Here is the overall survival and the progression-free survival visualized as a Kaplan-Meier curve. The blue curve represents the survival of group 1, and the green curve represents the survival of group 2. As you can see, the majority of the patients in group 2 had better survival than group 1, and the difference was statistically significant. Here is the response data, group 1 in blue and group 2 in green. As you can see, 1/5 of patients in group 1 progressed, and nearly the same proportion of patients had stable disease and partial and response in the imaging. And in the second group, about 5% of patients progressed, about 1/3 of patients had stable disease, and nearly twice as many responded. Therefore, in conclusion, we found that group 2 had better progression-free survival, better overall survival, lower death event rates, and better clinical benefit rate. This is only a hypothesis, but we think that somatostatin analogs may play a significant role in tumor control in patients with neuroendocrine tumors who underwent PRT as a combination therapy and a maintenance therapy. Thank you.
It is open for discussion. Is there any question? Thank you. Please wait for.
So next presentation is Dr. Ismail Lowell from South Africa. Title is Fluorinating FDG PET-CT Metabolic Parameters in Evaluating the Effects of Human Immunodeficiency Virus Infection on Tumor Volume and Response to Chemotherapy in Patients with Hodgkin Lymphoma. Please.
Thank you, Chairperson. Ladies and gentlemen, I'm grateful to the organizers of this program for this opportunity to present our work, where we looked at the impact of HIV infection in patients with Hodgkin's lymphoma. I have nothing to disclose. Okay. As a background, and to start from the good news, is the fact that HIV patients are now living longer, such that the survival among HIV-infected patients is not approaching those of non-HIV-infected patients. And these are largely been there as a result of the successful introduction of combination antiretroviral therapy. However, the better survival that has been recorded in this HIV patient has been in the better control of infection associated with HIV infection. That's other opportunistic infection this time. However, we're winning the war with infectious disease, but now we're having a new problem, and these are HIV-associated cancers, which are now emerging as the leading cause of mortality among this group of patients, such that in very developed countries, the leading cause of death among HIV-infected patients is now HIV-associated malignancies. There are two categories of these cancers. There are one called AIDS-defining cancers, which, with successful introduction of combination antiretroviral therapy, have also been reducing. However, the other group, the non-HIV, non-AIDS-defining malignancies, have not witnessed similar improvement in incidence. And in fact, in some series, there have been increase in the incidence of non-AIDS-defining malignancies. Hodgkin's lymphoma is the most common type of non-AIDS-defining malignancy, and there is paucity of data as to whether HIV infection actually impacts on prognosis in patients who have Hodgkin's lymphoma. Some authors have reported the presence of high-risk indicators in this group of patients, which did not translate into therapy impact. So we decided to use FDG metabolic parameters, which has been found in most human malignancies to predict survival, in order to evaluate the impact of HIV infection in patients with Hodgkin's lymphoma. So our aim was to evaluate the impact of HIV infection on tumor burden and therapy outcome following treatment with erythromycin, bleomycin, vinblastine, dacarbazine in patients with Hodgkin's lymphoma. So what we did was to take patients with histologically diagnosed Hodgkin's lymphoma who were adults, and in all patients who had serologic confirmation of their HIV status. So all patients had a baseline FDG PET-CT scan, on which we determined the SUV marks of the most intense lesion. We also determined the MTV and TLG of all malignant lesions. All patients underwent chemotherapy which was based on the institutional protocol. So if a patient has stage 1 or stage 2 disease without a bulky disease, they had 2 to 4 cycles of ABVD chemotherapy. If a patient has stage 2 disease with bulky disease and other higher grade of disease, they had 6 to 8 cycles of chemotherapy. So upon completion of chemotherapy, all patients also had a repeat FDG PET-CT in order to evaluate therapy response. And we evaluated therapy outcome based on using the Duval 5-point score. So if a patient has score 1 to 3, it was considered as a negative scan. If a patient had a score 4 or 5, it was considered as a positive scan or treatment failure. So this was the baseline of the baseline characteristics of the 136 patients that we included in the study. Our patients were relatively young at a mean age of 32, with a range of 17 to 69. We had more males compared to females. About half of our patients had stage 4 disease, so it was a widespread disease. And among this 136 patients, 57 of them were HIV positive, whereas 79 of them were HIV negative. So we compared this baseline characteristics between the HIV positive patient and HIV negative, and we found that there was no significant difference between in the age of this patient. Yes, however, a female patient with Hodgkin's lymphoma is likely to have HIV infection compared with a male patient who is likely to be non-HIV infected. And there are also no significant difference in terms of the anabolized stage of the patient. So these are the FDG metabolic parameters seen in the patient. So this is the SUV max, HIV positive, HIV negative. If you notice the mean for the HIV, it's the median score for the HIV positive patient is slightly higher. However, it was not statistically significant. Same thing for the MTV and TLG, whereas these values were slightly higher in the HIV infected patient, but there was no statistically significant difference between the HIV positive and HIV negative patient. We evaluated the impact of HIV infection on the treatment outcome and found this infection, so those who are infected are likely to have treatment failure, to still have residual disease post-treatment. Again, we used a binary regression to determine if any of those factors was a significant predictor of treatment outcome, and we were able to demonstrate that HIV status was a significant predictor of treatment outcome, whereas the FDG metabolic parameters were not. SUV, MTV, TLG, as well as the stage of the anabolized stage of the disease were all not significant predictor of treatment outcome. So we in a multiple regression analysis, we combine all of these factors to still see if HIV infection remains a significant predictor, and yes, it still remains a significant predictor of treatment response. And this is an example of a patient. Sorry. Okay, this is a 46-year-old HIV-infected male patient with lymphocyte predominant Hodgkin's lymphoma. On the baseline PET scan, there is multiple nodal involvement above and below, minimal above the diaphragm, with liver and splenic involvement. After treatment, still had persistent disease in the pelvic nodes. So this is one of the patients who classify as treatment failure. This is a different patient with a older, similar variant of Hodgkin's lymphoma with more widespread disease, with involvement in the liver, spleen, multiple nodes, and bone marrow. However, after completion of 8 cycles of chemotherapy, this patient was clean, had negative. So this is a patient we classify as a successful treatment. So in conclusion, from our data, we're able to say that if HIV-infected patients are diagnosed at similar age and disease stage compared with HIV-uninfected individuals, and that female patients with HIV, with Hodgkin's lymphoma are more likely to be HIV infected compared with males who are more likely to be HIV negative, and that FDG PET metabolic parameters are similar in both HIV infected and uninfected patients with Hodgkin's lymphoma, and that HIV infection appears to be associated with poorer treatment outcome, and that and this may suggest that HIV infected patients indeed need more aggressive treatment. And thank you very much. Future perspective. So we think probably that it's important to see this treatment outcome if it actually translates into prognosis looking forward. And finally, thank you very much.
Thank you for presentation. Now open for discussion. Okay, thank you for presentation.
Thank you. Please to go. The last paper in today's program by Brazilian Dr. Luis Salazar, that is on allium-68 dotated PET-CT in the guidance of surgical management of neonatal. Nothing else. Neonatal.
Yeah.
Huh? It is written up to that. Okay. No, this is yours.
Yeah, don't worry.
The title is not complete, actually.
Yeah, don't worry. The name of this work is 68 gallium dotatate PET-CT in the guidance of the surgical management in neonatal hyperinsulinism. My name is Luis Salazar. I'm from Chile, not from Brazil. This is. It's not working. Okay. I know this disease is not a frequent disease in nuclear medicine centers, so I spent some slides to explain the background of this disease. Congenital hyperinsulinism, or CHI, is an uncommon disorder of the glucose metabolism, but it's the most common cause of persistent hypoglycemia in the newborn. The symptoms may be mild and non-specific, but maybe will be severe, such symptoms like apnea, seizure, or loss of consciousness. The pathophysiology of the disease is an excessive production of insulin by pancreatic beta cells with high level of insulin and C-peptide with low glycemia levels. And the problem is the high risk of brain injury and the negative consequence of neurological development of the newborn. So the recently studies show that an early treatment and prevention of hypoglycemia can prevent the brain damage. So it's necessary an aggressive approach of this patient. I take this slide from a Congress of the 2013 that show the reality in Latin America. It's a very infrequent disease and probably underdiagnosed, but this is the most important thing. Most of the 50% of the patients are diagnosed after the 3 months of life. This is a very poor prognosis. If you search in the literature, you can find a lot of guidelines and management algorithms, but I will resume in this algorithm. I prefer explain part by part. The first thing you have to do is, after the diagnosis is made, you have to treat with diazoxide. Diazoxide is the first medical treatment therapy. Have the the mild side effects. If the patients don't respond to diazoxide, you have to make rapid screening genetic testing. Why? Because congenital hyperinsulinism is an heterogeneous disease, and some genetic mutations are related with different subtypes of this disease. Historically, we have two main subtypes, the focal or diffuse subtype, but some studies in the last time show that we have real three main subtypes with a new subtype called or named atypical subtype. Why is it important to classify the patient in this subtype? Because they differ in their treatment approach and prognosis. Some patients benefit from medical treatment, other patients benefit from surgical treatment, and the surgical technique will differ from an inoculation of the lesion or a nearly total pancreatectomy. What's the problem with this algorithm? Genetic test is not available worldwide. Probably in developing countries, we don't have genetic testing, and the result can delay from days to weeks. Then the next step in this scheme is made some molecular imaging. Why? Because the radiological techniques are not useful for this pathology, and some studies show that a highly accurate of this radiopharmaceutical in distinguish between focal or diffuse subtype. And also the molecular imaging helps to guide the surgery and the option to do a minimally invasive pancreatectomy in this patient. What the same problem? This technique is not available in many countries. In the countries that is available, it's only in specialized centers, and also it's very, very expensive. So what we propose, because genetic testing and FDOPA is not available in many countries, gallium labeled with peptide somatostatin analog might be an alternative to select what patient will benefit from this minimally invasive technique. Why gallium? Because somatostatin receptors are related with control of insulin secretion. Other neuroendocrine disease overexpress somatostatin receptors. A gallium datate is approved at FDA for pediatric PET imaging and for the experience of our center. A last background slide. It really matters why we only do not treat the patient with a second or a third line of treatment. The first reason is 65% of this case don't react to medical treatment, and the medical treatment, the second and third line of therapy, have high rate of side effects. And what the problem with a near total surgery? A near total surgery is usually considered as the last option in management because some infants remain unstable with persistent hypoglycemia and require a second surgery and have a lot of complications. In acute phase, the most important complication is infection, but in a chronic phase, the incidence of diabetes and exocrine pancreatic insufficiency is near to 96%. So we can try to avoid this type of surgeries. We know that nearly 2.5 of these patients of unresponsive to diazoxide are focal form, and the focal lesion can be completely cured with partial pancreatectomy. So go to the result. We select a sick newborn with unresponsive congenital hyperinsulinism and normal radiologic imaging. These our selection criteria. We perform a PET-CT 35 minutes after injection of gallium datate, and this was reported by 2 different nuclear medicine physicians and 2 trained pediatric radiologists. This is one of the results. One patient present a high uptake of the radiopharmaceutical in the pancreatic body near to the origin of the splenic vessel. Obviously, the CT was normal. So this patient underwent to a laparoscopic pancreatectomy. The surgeon described a nodular lesion near, very near or attached to the splenic vein, like the PET-CT shows. The biopsy described a pancreatic tissue of partially distorted architecture. The rest of the sample was reported preserved morphology. This is concordant with a focal subtype of chip. We have the opportunity to make a genetic testing in this patient. This patient, this patient progressed really favorably, rapidly achieving a normal glycemia without medication and was discharged 10 days after surgery without any drugs. And at 3 years of follow-up, he remained eutrophic, normal glycemic, and had normal psychomotor development. This is the important part. The genetic testing, the delayed genetic testing shows a mutation in this gene who is concordant with a focal lesion, and this type of genetic mutation will not respond to medical treatment. This is the perfect patient that will benefit from a minimal surgical surgery. This case report was published in the last year in the Revista Chilena de Pediatría, and was the first case report that was successful. I forget the word. Sorry, doesn't matter. We have also 2 patients with diffuse uptake. The patient with diffuse uptake don't show any alteration in computed tomography. At follow-up, they was managed with medical treatment, with good metabolic control, mild side effects, and normal neurological development. One of these patients at 14 months of medical treatment were discontinued. For this reason, surgery was not needed, and we don't have biopsy of this patient. This patient underwent 2 genetic testing, delayed genetic testing, and this testing was negative for focal lesions. So they are concordant with the nuclear medicine imaging. Sadly, we have 3 normal uptake patients. This is not what I want, but initially we have 4 patients with normal uptake, but we luckily repeat one of these patients, and this was the first patient that I show some slide after. This patient probably have a normal uptake because he was treated with octreotide the last days before the PET-CT. We have 3 other patients with normal uptake. 2 of these patients were discharged with their reference, and we don't have follow-up of this patient, but one of these patients at 2-month follow-up have severe hypoglycemia without glycemic control in spite of medical treatment. He was treated with a 2nd and 3rd line therapy with a high side effect, immunosuppression, sepsis, renal infarction, gallbladder stone, and the genetic testing in this patient show a very, very difficult, a very hard to treat mutation, but these mutations are not related with focal subtypes, so it's not a bad result. While we have normal results, this can be as with our work, but we have some hypotheses. One of this hypothesis was the radiopharmaceutical interaction with octreotide. Some other option was the lesions are so small to see in the PET-CT. One of the most important hypotheses was the atypical disease, because the atypical disease is not a really lesion. It's maybe a dispersed and normal neuroendocrine cell, like a mosaicism in the pancreas cells. The conclusion of these cases are the CHI is a rare disease, but it's the first cause of persistent hypoglycemia, and this confrontation must be fast and aggressive, and the study should be oriented to discriminate the diffuse and focal form, and the PET-CT have a fundamental role in these cases. the PET-CT with K-labeled peptide somatostatin analog is a reasonable alternative to F-DOPA in guiding surgical approach in patients with CHI if the later radiopharmaceutical is not available. And this was the first cause report when gallium DOTA-PET-CT successfully guided surgery in patients with CHI. This was the previous case, but luckily, I don't know if the author of this paper is here, but in the other side of the world, in India, the last year, other group showed the same result that we show in our first case. And a patient with a focal subtype of CHI successfully treated with a minimally invasive surgery. So this is a good thing because they are we have the same result that the other group and in different contexts. So we need further study to confirm its finding. We need to make more protocol and bigger study to explain what are the best patients that benefit from this protocol. Thank you.